I can tell I'm the kind of the postprandial, we're all a little sleepy. I feel like I should get ready to get up and dance a little bit, but I promise I won't make you do that. So I want to start off, I don't have any conflicts of interest or financial ties to disclose. I will say the Academy has 67,000 members. We are bipartisan or nonpartisan, but we're unabashedly pro-child. So if I talk about anything, it's from the perspective of the child. And I thought I'd start off first because whenever you have somebody come speak to you, you kind of want to know who they are. And there are a number of people here who are really good friends who I know really well. But this is a picture of me after having had an emergency C-section with my 2-year-old. You can't see, but she has, remember Cabbage Patch dolls? She has a bad Cabbage Patch doll in her hand that she named Baby Jesus. It took us a long time to figure out why she named it Baby Jesus until we went to her preschool, and for Christmas that year, Baby Jesus was a Cabbage Patch doll. So it was always very embarrassing if you're not, you know, I can't say it, evangelical family when your daughter is going, no, Baby Jesus, don't do that. But I was breastfeeding for the first time in the recovery room, and my daughter was wanting to know how she could feed Baby Jesus. And so it was really an interesting, the poor thing ended up with the most bruised nipples because she kept hitting her chest with Baby Jesus, trying harder and harder. But the interesting thing was when I had Kathleen, the 2-year-old, I was in private practice, and I was at the hospital where I was there to care for babies every single day. And I said to the nurse when she brought her in, you know, I may be a pediatrician who talks to people about breastfeeding all the time, but this is the first time I've actually been a mom. Would you please treat me like you would any other mother? And she said, sure. She handed me Kathleen and walked out the room. And I went, okay. So it was 1988, and I realized all I had to learn, I learned by trying to find it. We didn't have the internet the way we do now. And then I finally went to my patients' mothers and said, what do you guys do? How do you store your milk? How do you make this work? And so you fast forward, here was a children's hospital, the King's Daughters. I worked nights in the ER. I would go to the NICU to pump because that's the only place there was a breast pump. I always felt sorry for those moms because I'd walk out with 12 ounces and they'd look at me like, which one of these babies is yours? And I'd be like, no, it's a 6-month-old at home. But I spent a lot of my time nights in the ER talking to moms that were having problems breastfeeding. And I realized, you know, they would come finally in the middle of the night panicked because they were so afraid they were starving their baby was sick, they were tired. And so really began to realize that I didn't have the knowledge I needed. But continued to work that through, and this is, I was the Commissioner of Health for 2 governors in Virginia. I was hired by Governor Kane because of the amazing discrepancies we had in our infant mortality rates. And we had, for what is thought of as Virginia kind of being a middle to high income state, we had horrific infant mortality rates. So one of the things we did, besides looking at the classic public health way, is we brought everybody in, and we learned that if we could increase breastfeeding rates, we could decrease infant mortality rates. So that was a big part of the push when we were there. While I was health commissioner, there were 2 brilliant women. Natasha's one of them who's here, another one who came to me and said, we want to start a milk bank. And are there any regulations we need to know about? And it was interesting because I said, gosh, I don't know. When we were talking about, we went to the FDA. I talked to UNOS because they're the organ donors. We're like, this is blood, but it's not blood. The funny thing is I also regulated milk plants. And so I was able to go to my environmental health people and say, is the way they're pasteurizing this milk the way you would pasteurize bovine milk, and does it make sense? So I bring that up because I learned so much more about what it takes to have a milk bank and how that can impact public health if they had not come to me. So those of you who are thinking about local public health and state public health, most of your public health officials don't know what goes into a milk bank. How do you do it and make sure it's safe and effective? They regulate, you know, everything. I mean, I regulated everything from septic tanks and sewage to hospitals and everything in between, but I'd never thought about a milk bank before and what were the things that really mattered for safety. And once you've talked to your local health director or your state public health person, they become your fierce advocate. They will show up when your milk bank opens. They will be there for you. They will talk about it with stakeholders. So get them engaged and involved. And here is the day the milk bank opened, and it's very successful in Eastern Virginia. And so now we move on to the academy. So I always say the academy looks at things from 3 different perspectives: education, policy, and advocacy. And the good news is you all have showed most everything I'm going to show already today from the academy. The good news about the Academy is we are a trusted source of information about children and children's health around the country. So let's look at what we do around education. So these are kind of the most go-to books in terms of the New Mother's Guide for Breastfeeding, which actually is one of our very best-selling publications. Clinicians keep them in their offices, people order them online, and then we have the Breastfeeding Handbook for Physicians. In Bright Futures, which is it's funded by HRSA. This is sort of the national anticipatory guidance. The majority of states use this as their anticipatory guidance. We talk about breastfeeding in 18 different places within Bright Futures so that pediatricians know when they use this, or public health nurses, to continue to have the conversation. They begin when the patient comes in, the parents come in for that first visit to interview you about whether they want you to be that pediatrician and continue on. We talk about healthy weight, we talk about healthy development, we talk about the health of the community and how breastfeeding impacts that. And then we also work very closely with the CDC, and I don't know if you're going to talk about this. Are you good? Or we all are just good friends together. That's the nice thing about it. But I think what's important here is we realized, both the CDC and we realized, that the tools that the pediatricians had at the bedside were not incorporating what we know about motivational interviewing. They were not incorporating all of the knowledge we know about how to have conversations with families, how to meet people where they are. I think you guys talked about it a few minutes ago. Instead of saying breastfeeding is best, which says if you don't pick it, you're a bad mom, that you say, okay, what are you thinking and where do we go and how do we go from there? So we're partnering with the CDC to develop not only educational models, but then we're going to work to say, did that educational model fill the gap? And part of the problem that we've always had is we don't go back and do focus groups with the parent, that mom, and say, what did you actually hear? When Dr. Remley talked to you, she thinks she gave you a really good conversation and walked out of that door thinking, you're all on board. What did you actually hear? And what were the things she didn't say or the questions you wanted answered? We also have the Institute for Healthy Childhood Weight, where we talk a lot about the impact of breastfeeding on preventing children being overweight. As you can see, this is one of the areas that motivational interviewing really came into play. When this institute was started, they called it the Institute Against Obesity, and then we did focus groups with parents, and they were livid. So that's why it's an Institute for Healthy Child Weight, to do what we can for every child everywhere we are. In this, there are, again, modules around breastfeeding, around encouraging parents to understand why it's important. We also have, through the section on breastfeeding, educational grants, because I think we've all talked about today the gaps in knowledge for pediatricians, for general physicians, that we really don't have in the curriculum for ACGME, and when we're looking at pediatric residency, enough information about this critically important part of care for children. We've expanded through our disaster preparedness group and our breastfeeding group to talk about how do we support children during emergencies. During the Puerto Rico hurricane, a large number of mothers in Puerto Rico breastfeed, but they didn't have access to safe water. And so there was a big push in that first week from the federal government to give them all pre-mixed formula. And we said, instead of doing that, let's figure out how to get water to the moms so they can continue to breastfeed, because especially during an incredibly stressful time for everyone, being able to maintain the normalcy of breastfeeding was very important. So that's what we do around education. We do a lot more, but I'm going fast because I know we got a lot to cover and want to see if you all have questions. Policy, you've seen these. So our policy statements are very carefully written by authors who research, look at the evidence. Normally, we try to be evidence-based whenever possible. If there isn't enough evidence, then we're evidence-informed. And if there isn't enough evidence, then we're consensus from those that are going to be the best thought leaders. They go through a very rigorous process of having multiple different groups within the academy review that policy statement, and then it finally goes to the board for approval. The reason why we're so thoughtful about that is we know that this policy statement is then used in a lot of different places, whether it be to support activities that other people do, other groups do, or to show to stakeholders. So we talked about breastfeeding and the use of human milk. We had the prevention of rickets and vitamin D deficiency in infants, children, and adolescents. Very important because we know that what we put out sometimes has an impact on what insurers will cover. And so it's important that we're very thoughtful again about what we recommend and don't recommend, because when you're going to argue with the insurance company to pay for it, you can say, but the American Academy of Pediatrics recommends that we do this. This is very important, the donor human milk for the high-risk infant, preparation, safety, and usage options for the United States. I'm going to read the 5 key points because I think it's really important for us to all hear. Although a mother's own milk is always preferred, donor human milk may be used for high-risk infants when the mother's milk is not available or the mother cannot provide milk. Human milk donors should be identified and screened by using methods such as those currently used by Habama, milk banks, or other established commercial milk banks. Donor milk should be pasteurized according to accepted standards. Healthcare providers should discourage families from direct human milk sharing or purchasing human milk from the internet because of the increased risks of bacterial or viral contamination of non-pasteurized milk. The use of donor human milk in appropriate high-risk infants should not be limited by an individual's ability to pay. And that was a very important 5th statement because we wanted to make sure for all of the NICUs and neonatologists in the country, it shouldn't be if you can afford it, you get it, and if you can't, you don't. The breastfeeding-friendly pediatric offers practice. We're still working on this. There are some pediatric practices that are incredibly pro-breastfeeding. We have some pediatric practices. I heard a very respected pediatrician say, I don't bother bringing moms back at 1 week. I bring them back at 2 weeks because either they're going to be successful breastfeeding or they won't. It was just sort of like, it's an all or none. And so you realize within our own profession, we have a lot of work to do and a lot of different perspectives from people. We certainly support baby-friendly hospitals, and really, though, what I want us to think about is how do we move beyond just a baby-friendly hospital that occurs in the neonatal area, that occurs in the nursery, but the whole hospital becomes a baby-friendly hospital. The AAP has an evolving approach to our industry partnerships. One of the things that's hard for the Academy, like many medical societies, is, when I first came, and historically, a lot of money would come from pharmaceutical companies and formula companies to fund activities at the Academy. Over the last 3 years, we've developed much more stringent guidelines in how we interface with the industry and what types of money or funding that they can be involved in. The breastfeeding section very clearly said they did not want educational programs sponsored by the formula companies, and we continue to work with the board to continue to pull back on how do we do that, and how do we do it in an ethical way that makes sense for everyone. So last is advocacy. And one of the things I learned when I was a state health official, and I try to continue, is to say be first, be right, be credible, but you always have to be all 3. And you have to add being empathetic in there. So that's been our approach, especially with this new administration, is to say we have to be first, right, and credible, and we have to be there for children. So in the Blueprint for Children, which is a book we put together at the beginning of this administration, knowing that regardless of who became president, President Obama and his administration had been there for 8 years. So we knew we would be starting, if Mrs. Clinton won, we knew we'd be taking off running behind her because she had a lot of children's issues she wanted to work on. If Mr. Trump won, we weren't sure where he was going to be with children's health issues, so we wanted to have a really good template. And so we put together this blueprint looking agency by agency about what needed to happen for children. We've advocated for a variety of new laws. I think some of them have already been discussed today. Breastfeeding in public or private location, that now is a law in 49 states and DC. Exempting, this is hard to even say out loud, breastfeeding from public indecency laws. It's only in place in 29 states. You think about those other states. Breastfeeding in workplaces and exempting breastfeeding moms from jury duty. They sound like small things, but they're important things because it makes the statement to the community that this is something we value. Around WIC, we've been advocating for funding of the breastfeeding peer counseling at $90 million, as you heard about earlier today. I think he's here somewhere, but we don't think it should be cut short. We think it should be the full $90 million. We think this is really, really important for children and mothers. And you heard about the modules that we have in airports. We've also been a key supporter of the bicameral Friendly Airports for Mothers Act. that will require this in all airports. It also is part of the FAA reauthorization package, which importantly will include on all planes of a certain size medication and emergency equipment that will work for children. Right now, when you fly on a plane, there are no pediatric emergency equipment. So when a child has, I had a child who had a seizure a couple months ago, and I had to figure out doses of adult medicines and adult needles and an adult oxygen mask to work for a 9-month-old. When this goes through and it's funded, hopefully, where's what? We'll be able to have the right equipment for children. And this is the Task Force for Research in Pregnant Women and Lactating Women. I think we've already talked about that. This is what came out of the 21st Century Cures Act. We have worked hard with Anthem, my old employer, for a short period of time. We are advocating very strongly to have them not cut the funding for the breast pumps. We've met with them a number of times. We've had partners, ACOG, the Society for Maternal Fetal Medicine, and ABM. We all went together to send a letter. We are meeting with them in the next month to have a face-to-face conversation. I'm proud to say that we have a couple of members who will bring their breast pumps to demonstrate exactly why this is important, because I think sometimes people don't know until you see in front of you exactly what you're talking about. And so we've got, very strong and brave members who are going to bring it all and show it all so they will understand. And then we also certainly advocate for the Supporting Working Mothers Act. We know that it's still very difficult for women to continue to pump and engage in breastfeeding when they go back to work. And with that, this is where I'm going to ask you all a kind of a provocative question, because as we look at the future, here's the percentage of primary care pediatricians who make breastfeeding recommendations across time. So this should make you feel good to start off with, right? So in 1995, only about 43% tried to make sure babies breastfed within 1 hour of delivery. Now, 92% recommend that as of 2014. Give nothing but breast milk unless medically indicated. We've gone from 79 to 93. Rooming in 24 hours a day, we've gone from 51 to 86. Unrestricted breastfeeding, we've gone from 59 to 73. So this shows you where there's some generational differences, and we're still not there yet, right? No pacifiers in the hospital, 23% to 47%. So there are still gaps in our members' knowledge and our members embracing breastfeeding as important as it should be. And now when we really lean into the future, this is what I think is crucially important for us to think about. The field of medicine is becoming female. If you look at, this says that 55% of OBGYNs are women and 53% of pediatricians, but if you looked at residents, it's 73%. So women of the pediatricians of childbearing age, 3/4 of them are women. So they are going to be, and what is it? Okay. So 82% of OBGYN residents. In surgery, my daughter's in a surgery program, and for the first year ever, they have one more woman than they do men. So the field is changing quickly. These are all women of childbearing age. And has anybody here ever gone to I forget what the name of it is, but it's like a breastfeeding mom doctor Facebook group? Thank you. You go there and you read about, what do I do when I have a 7-hour surgery case and I can't pump, and can the nurses come behind me and get my milk? And I read it and thought, oh my God, we have failed as a health system to even empower the women who are going to be teaching other women and talking about breastfeeding to be in a friendly environment. And that's why I say we have to work collectively to make the entire hospital system and healthcare system breastfeeding friendly, not just the nursery and the delivery room. Because these women are all quitting when they go back 6 to 8 weeks. They are all faced with a very male-centric, don't ever complain, medicine has always been toughen up, do what you can. So we're putting them in a very awkward situation. If they are supposed to be the role models for their mothers and their patients, we have to figure out a better way to empower them. So I encourage all of us to talk to the American Hospital Association, the AAMC, the residency programs, because we've got to have all the things you talked about here today and bring that into the healthcare setting. Because again, and I forget who it was that said, if you have not just a milk bank, but you have a place where people are actively breastfeeding, and if I'm seeing an internist and she says, I'm sorry, I need to go pump for 10 minutes. That's why I was a few minutes late to your visit or whatever it was. It becomes part of what we think is normal, and it normalizes all the behavior. Why is this important? So this is another way to think about it. This is our annual meeting. Look at the age group of people who come to our annual meeting. So 27 and 26% are in that age group, right? And look at how many are female. So I will tell you that in 1988, about 5 months after I had my baby in that picture, I went to our national meeting in San Francisco. I took my little battery-operated Medela pump, which was the first year they had a battery-operated one. I pumped in the women's bathroom and dumped it down the sink every 4 hours. And people would come in and say to me, "What are you doing?" Because hardly anybody was pumping and breastfeeding then. And I didn't go back to a meeting for years because it was like, this is just not worth it. And my baby's more important than coming to this meeting. So it's changing. We will have a Mother's Milk Bank of Florida at our meeting this fall. We are encouraging all of our members who are breastfeeding at the meeting, and we have lots of access to breastfeeding rooms, to donate milk while they're there to be able to help the Milk Bank of Florida. We're hoping if this works well, we can expand it to other medical society meetings because, again, what are we going to have? A whole lot of women who are of childbearing age who will be breastfeeding, and how do we make this normative behavior? When we have this at the cardiology meeting, we will know we've made it, or the urology meeting. I can see that. But I think it's really important, and it speaks to what we were talking about this morning. How does it just become part of society, where it's just normative behavior to have this instead of the exception? The other thing is when you're an employer, and we are at the academy, it's important to practice what you preach. So we now have 16-week maternity and paternity leave. So regardless of whether you have given birth or you've adopted, if you're a mom or a dad, you have 16 weeks of family leave. And then, again, other ways to think about this. Somebody came to me and said, gosh, Natasha's smiling over there again, but it was very difficult for, again, those women of childbearing age who were taking their boards, right? So they have a big day in your life to take your boards. How you kind of get the ticket to go on to the rest of medicine, and they're breastfeeding. And they don't have time to be able to stop and go pump. And you don't want them to be uncomfortable. You don't want them to be leaking in the test. You want them to be able to have the time. Reaching out to the American Board of Pediatrics, we were able to get them to do this, but no one had really thought about it before. And so one of the things I think we need to talk about, and I'm looking at Natasha, is how do we go to the American Board of Medical Specialties and make that be, again, normative behavior, so it's not a one-off. It should be the same thing for the American Bar Association, or any of these things are things we should be recommending to people that they put in place. You heard a little bit about the 21st Century Cures Act. I think the most important thing there, and as we heard from the NIH, is that we will be able to include children in, everybody across the whole lifespan. I'm not sure if my hand looks that old yet, but we're getting close. But it's important. And then two last things that are exciting. The Academy has decided to start a child health registry. That registry will be child-centric, not disease-centric. So imagine that you could link with our OBGYN people and start a registry when mom's pregnant and enter clinical information, but we also will enter parent information and patient information. Because I always say one of the things moms and dads always asked me was, will they go to school? Will they be able to graduate from high school? How many days of school will they miss? And those are a lot of questions we never collect because HIPAA data and FERPA data never talk to each other. We will be able to, hopefully through this registry, connect to other registries. So you've got a child who was breastfed, and you want to figure out, when they have problems with nephrotic syndrome down the road. Are they related at all? Are they not related at all? Is there anything we can learn from that? The nephrotic syndrome, the kidney problems, live in the nephrology database. How do we import that in and be able to look at the whole child? The child who's been a preemie, who's in the Vermont-Oxford registry, and there's all kinds of information there, but nobody's following them for years. Having them as a registry will allow us to do that. And then the other thing it will allow us to do that we talked about earlier today is we have a whole lot of children who, most of my career, at least once a night, I was using a drug that was not approved for children because the FDA no one had ever researched using the drug in kids, and I would have to say to a parent, this is the right drug, but it's not approved for use in children, we have to use it. We'll be able to look post-marketing at those drug use and see if there's signals, if there's problems. We'll be able to hopefully answer some of those questions about taking this drug and breastfeeding. Does it have an impact or does it not? How do we learn from those things? And then lastly, because it doesn't really have anything to do but it does with breastfeeding, but it really does, because we talk about breastfeeding because we know it's the most important thing we can do for babies in terms of their first food. We now have, we have more children dying from gun violence than car accidents. That is just unbelievable to me as a pediatric ER physician by training. It's horrible in that I cared for many children who were shot, and many who died, many who did not. When I was in the ER, and I have a daughter who's a surgery resident who, second generation doctor, is caring for even more. So we at the Academy thought about what haven't we done? What more can we do? And one of the things I did, and I always like to look at data to be able to figure out where we should go, and we looked at our data and we realized the number of pediatricians who felt comfortable talking about gun safety over the last 25 years has gone down. And we also looked at them, what do we tell them to say? And in Bright Futures, we tell them 3 questions. Do you have a gun in the home? So it's already punitive, right? Because if you say yes, you think the doctor's now going to yell at me, right? Because the second thing we say is, if you say yes, you say, children are safer in a home without a gun. So I've made my second judgment about you. And then I say, but if you keep the gun, lock up your ammunition and the gun somewhere else. What we know is if you live in Delaware, less than 5% of people have guns. But if you live in Wyoming, 52% of homes have guns. So you have to have a better, more nuanced conversation. So we're putting together an initiative to learn through focus groups, through working with public health and other groups, what should that conversation be? How do we test it and make sure the message resonates? How do we make sure that those patients and parents heard that message the way we thought it came out so that we can actually hopefully save some children's lives? We'll continue to do all the work we do advocating for common sense gun laws and for research. We're also looking at what is all the other research out there that we don't know about and get that together. We don't even know when is it time to have the conversation. So do you have the conversation during the prenatal visit? Because that's when people are scared to death, right? And that's when they'll do anything to have a healthy baby. But when do you have the conversation with an adolescent who might be exposed to guns? Do you have it with every adolescent? Do you have it with high-risk adolescents? We know that in certain communities, if you're more likely to kill yourself with a gun than you are to be killed by a gun. In other communities, it's reverse. How do we message this and how do we work on it? So that's one of the things we're tackling next. And I know it wasn't breastfeeding specifically, but I'm excited about it and think it's something real important for us to do and we'll work on together. And I will stop there and see if you guys have any questions or thoughts. Yeah, whatever's easiest. I think you got it now. You either have to yell or there might be a button. I don't know.
It's not in.
There you go. Oh. There you are. Now,
Okay.
you're the voice of God.
Okay. I'm Melissa Bartik from Massachusetts. I have a question regarding SIDS and tobacco. So we know tobacco is responsible for preterm birth and a lot of infant mortality, and when bed sharing is responsible for a lot of infant deaths. And I came across the AAP's position statement on tobacco, and there's a lot of data now that increasing tobacco prices is the biggest thing that one can do to lower smoking rates, and that is interestingly not in the AAP's position statement on tobacco.
That was written before I came, but
Yeah.
You're right, it's not. We do advocate state by state. The board decided not to put it in there, but state by state, we work with each chapter to try and put in place higher taxes. Because it is, you're right, it's 100% the fastest way to do it.
Yeah. There's a new study that came out, I think in the last year, about in Europe, the marked decrease in infant deaths, thousands of infant deaths decreased when prices were increased in Europe.
Yeah.
So I think it's very compelling, and it would it'd go a long way if AAP advocated for increasing tobacco prices and prevent a lot of infant deaths.
So we advocate, but I think that Rachel Moon, who was the head of the Safe Sleep group, and that policy statement that came out again 2 years ago, talks about it in that policy statement, but the tobacco group is actually rewriting their statement. So I would firmly think it'll be in. I think the other thing that'll be in there that is really difficult, that, and you know, I look at all of us, we're transitioning from a world of tobacco in cigarettes to a tobacco in jewels and vapes. And, you know, many of them are twice the concentration of nicotine. And I am not an OBGYN, but I don't know what that does to placental blood flow. I don't know what it does to adolescent brains. And so we are talking feverishly to Scott Gottlieb and his group to say, you know, we have this new drug out there, for lack of a better way to say it, that has high concentrations of nicotine, that we have mixed messages as a country because we've told people it's safer than having a cigarette is e-cigarettes, but nothing at all is safer than either one. And we think our adolescents are getting a lot of unusual messaging about that.
Let me ask a question. I'm on a hospital board, and the question about jewels came up at our meeting 6 months ago. How many of you know what jewels are? Raise your hand. Pretty good, but not everybody. So if this were a meeting of kids,
yes, they don't
in
know.
high schools, every hand would be up. And it's a phenomenal danger that we have no evidence.
So a Juul is a vaping device that looks just like a thumb drive. It looks just like a thumb drive. It costs $50 to buy the original one, and you charge it by putting it into your computer. And then you can load it up with mango, cool mint, cool cucumber, bubble gum, creme brulee. I mean, it is targeted and marketed to children. And you can buy it online, and you just have to say online, I verify that I'm over 21. Not only are children using them extensively, we're talking 12, 13, 14-year-olds, but it is now a way. I mean, I had a mother who said to me, my son, who used to make his money mowing yards, wants to make his money selling jewels this summer. And I said, well, that would not be a good way for him to be able to go to college next year, because he could end up in jail. That was a friend. I did get an email from a mother who said, my daughter, who is 16, is addicted to her jewel, and she needs to take her SATs. And I don't know what to do, because I'm afraid if she goes in with it, she'll get kicked out, but she's so nervous and jittery. If she doesn't have it, I'm afraid she won't do well on her test. And if I'm a pediatrician, I don't know how, we don't have drugs and we don't have protocols to wean children off of high-dose nicotine. And most of the drugs you'd use, the gums and everything else, aren't approved for use in children. So it's a real problem, and I think we need to really think about what it means for pregnant women and breastfeeding mothers at the same time as we try to talk about this emerging epidemic. Because I feel like in our country, we only look at the epidemics after they've been in our face for 5 or 6 years instead of the ones that are coming down the track.
Hi, thank you for that. Education, fantastic talk. I'm Lucy Sullivan. I'm the Executive Director of 1,000 Days, and just thank you for all the work that AAP is doing on so many different fronts. Shout out to the wonderful work that you're doing around immigration, because I think that also has a huge impact on breastfeeding and on mothers and on so many things. Anyway. Another thing for you to talk to Scott Gottlieb about, and that's toddler formulas.
Yes.
So that is something that is another emerging public health crisis. We know that parents are using toddler formulas on infants because toddler formulas tend to be cheaper, and they're often marketed under the same brand architecture, et cetera, et cetera. And these products are obviously not formulated for young children, lots of added sugars and all sorts of nasty stuff. They're unhealthy, they're unnecessary. We really need the AAP to tackle this, and please come out with a position on it, because these are considered breast milk substitutes, and it's important that parents are getting the right message about these products being unnecessary and unhealthy. Thank you.
And expensive, because they're still more expensive than regular food. I just
Exactly.
think if we could just give people a food grinder and leave it at that, but because but the Committee on Nutrition is actually looking at that right now and probably will come out with a statement. It is hard, because if you look at what the formula companies are now doing, they've gone from your Similac and Enfamil to will now create this new artificial formula where the proteins look closer to breast milk than they ever have before, and want us to say that's okay. And it's always really hard, because you want to say, well, no, the best food is breastfeeding. And yes, there are a few people who can't breastfeed, and so you have to have alternatives, but you can't market it as it's even better than breastfeeding, or it's easier, it's more efficient. And I think it's an interesting dance. It's an interesting dance even at the academy, for people who've been very involved in those companies versus people who have not. I'm looking at Natasha, who's been on our executive committee for the section on breastfeeding, and the discussions are always fascinating for me to sit and watch as the member leaders have them. But I think it's incredibly important. And the other thing we haven't talked a lot about today, and I don't know, it's probably beyond the scope of today, but how do we talk to men about breastfeeding and the value of breastfeeding, and how do we normalize that conversation so they don't feel excluded, but they feel part of the family and they understand how important that is, and how do they support women as they're breastfeeding. And we have a lot to learn there in terms of cultural competency, in that some cultures, the men are much more embracing of breastfeeding than they are in others. So, good. Thank you, everybody.